All right, another one. Treadwell DPT, another episode of Anatomy Breakdown, muscle by muscle. Today we're covering a small muscle that generally gets overshadowed by Big Brother, but it's still a powerful one with a ton of clinical importance. We're talking about Pectoralis Minor. Not a beach muscle, not going to get you compliments in the gym, but when it's tight, overactive, or irritated, it will absolutely wreak havoc on your shoulder mechanics. Also your posture, and maybe even your breathing. So let's break it down. Pec Minor is a thin triangular muscle that sits deep to pectoralis major. It connects the front of the ribs to the scapula. It runs upward and outward, pulling the shoulder blade forward and down. If you were to hear that and think that it just sounds like it could play a huge role in your posture and shoulder health, then you'd be absolutely right. It's our only muscle connecting the scapula to the anterior thorax. To do that alone, it can be a major limiter when it comes to scapular motion in the superior and posterior directions. Pec Minor originates from the anterior surfaces of the third, fourth, and fifth ribs, near their costal cartilages. From there, its fibers run superiorly and laterally to insert onto that coracoid process of the scapula. This positioning gives it a direct line of pull on the scapula, enabling it to depress and protract that shoulder girdle. It also allows Pec Minor to anchor that scapula against the thoracic wall during our pushing or weight-bearing tasks that use that upper limb. Despite its size, its influence on scapular mechanics is huge, especially when it becomes tight or shortened. Quickly to reiterate our origin insertion, Pec Minor originates on the anterior surface of ribs 3 through 5, near their costal cartilages, and Pec Minor will insert onto that medial border and upper surface of our coracoid process. It's not often that we talk about this muscle's function, but it does serve its purpose, and its absence would be noteworthy for sure. We mentioned Pec Minor plays a subtle but important role in scapular mechanics and posture. It functions primarily to draw that scapula anteriorly and inferiorly, pulling it forward and downward against the rib cage. This makes it an accessory in scapular protraction and depression, especially during pushing movements or weight bearing through the arms. It also helps anchor the scapula to the thoracic wall, especially during those forceful downward motions or during resisted shoulder extension. Because of its connection to the coracoid process, the Pec Minor can also influence scapular tilt and positioning, often contributing to anterior scapular tipping when it's shortened or overactive. Pec Minor is considered an accessory muscle of respiration as well, aiding in the elevation of your rib cage when the scapula is fixed, although this role is usually pretty minor in healthy individuals. While not a prime mover in any of our strength or athletic tasks, the Pec Minor's influence on scapular positioning makes it a frequent culprit in clinical cases involving shoulder impingement. Also, we consider it with rounded shoulders or when we have thoracic outlet-like symptoms. So in summary, our Pec Minor stabilizes the scapula by pulling it forward and downward. It assists in scapular protraction and depression, and it acts as an accessory muscle of respiration when the shoulder is fixed. Pectoralis minor is innervated by the medial pectoral nerve, which carries fibers from C8 and T1 via the brachial plexus. Keep in mind that Pec Major is innervated by both the medial and lateral pectoral nerves. Definitely an important detail that helps differentiate the two on paper. Pec Minor is the smaller of the two muscles and does a lot less than Pec Major, so maybe it makes sense that it only has a single innervation. Interestingly, the medial pectoral nerve often pierces through Pec Major to reach that minor underneath. So that's another cool anatomical detail. Clinically, this innervation can become relevant for patients following surgical procedures like mastectomies, or we mentioned Pec Major ruptures in the last vid. You'd want to be aware of that innervation for sure, as well as that anatomy in situations of tendon repair as well. Very careful dissection is needed during those surgical procedures to preserve motor function, as well as to avoid any scapular abnormalities. So just to reiterate, Pec Minor is innervated by the medial pectoral nerve roots C8 and T1. Clinically, the pectoralis minor is notorious for being short and tight, especially in individuals with poor posture, forward head carriage, or rounded shoulders. When it shortens, it pulls the scapula into anterior tilt and downward rotation, leading to mechanical impingement of the subacromial space and increasing the risk of rotator cuff issues. We've got a lot of research that points to Pec Minor's role in posture and pathology. There was an APTA study done that demonstrated that scapular traction at 30 degrees of shoulder flexion produces the greatest elongation of medial Pec Minor fibers, making it our most effective stretching technique. In those with that postural shortening of the Pec Minor, scapular movement will definitely be altered, specifically with decreased posterior tilt and increased internal rotation during our overhead motions. These mechanics are very similar to what we see in impingement syndromes. It is interesting though, to those points, we've got some good studies that showed that daily Pec Minor stretching did improve pain and overhead function, but without leading to any significant changes in muscle length. That might imply that it's our neural or neuromuscular adaptations that are playing that more significant role in our shoulder rehab and pathology. Clinically, we've got what's called Pectoralis Minor Syndrome, which is just a fancy term for nerve or muscle compression beneath that Pec Minor. It's increasingly being recognized in overhead athletes, throwers, volleyball players, or Olympic lifters. Compression can mimic thoracic outlet syndrome with paresthesia or tingling, as well as arm weakness, or even chest or shoulder discomfort. Manual release, targeted stretching, postural retraining, these are all key to addressing that Pec Minor dysfunction. It's one of those muscles that shows up in rehab more often than you'd think. If you're working with overhead athletes, desk workers, or anyone with that upper cross syndrome, you definitely need to keep this muscle on your radar. So that's Pec Minor, rarely discussed, underrated, and in a certain sense it's not very muscly. Gym guys probably couldn't care less, and clinically you really only consider it for causing pain or pathology. If you're seeing shoulder pain, you're seeing postural collapse, or if you're seeing those thoracic outlet type symptoms, definitely make sure to look deeper and check this one out for sure. As always, drop a like, leave a comment, hit that subscribe button, and you'll keep up with this anatomy breakdown series. Much more in store, even more to come. Stay tuned, stay locked. Treadwell DPT. I'll catch you next time.